Thanks for your patience. I just found out I discovered that I needed more than 3 hours of sleep.
Dr. Katz is doing some work getting ready for tomorrow's conference, so he's not going to do the intro today. I am, but we're really honored to have Dr. Ronni Chernoff with us here from Little Rock. She is both, well actually she's got 3 hats. One is that she's Professor of Medicine at the GEC Center at UAMS, University of Arkansas for the Medical Sciences, is that right? Yes. Okay. And she also is the Associate Director for Education and Evaluation of the GREC there, and is Director and PI of the Arkansas Geriatric Education Center. So we have a lot in common. And except for the fact that she's an internationally renowned dietitian and a former president of the American Dietetics Association, and you'll hear a lot more tomorrow of interest as well. We're just going to talk on fluid and hydration today, and it should be a very enlightening talk. So welcome her, please. Thank you.
Well, thank you for your patience. Actually, Michelle and I have another thing in common that she didn't tell you, which was that we both were in the same graduate program at Penn. She got her master's when I was getting my PhD, and she was one of the subjects for my dissertation, although we didn't discover that for, what, about 10 years?
Yeah, we found out I should have been a social worker.
Which is sort of an interesting kind of thing.
Okay, so I can do the button pushing till she comes with the remote if you want.
Okay, you can push the button now.
Okay.
Some of you may be wondering, what's a dietitian doing talking about water? Well, water is probably one of the most important nutrients that we never talk about. For years, the GREC director, David Lipschitz, who was the original GREC director, and I used to go round and round and round on this because I always thought that fluid and hydration was one of the most important things, and that dietitians should be involved in some of the discussions about people's need for fluid and hydration and overhydration and underhydration. And he kept saying, no, it's a medical intervention. I kept saying, no, it's a nutrition intervention. So he's not the GREC director anymore, and I'm still saying it's a nutrition intervention. So, I guess I won simply because I'm still saying it and he's not.
You have more stamina.
That's right. My stamina is wearing out. Okay, next slide, please. I think that we probably all know. Am I in your way?
No, you're supposed to be in my way.
Oh,
Yeah, he's filming your head.
I bet I'd have to stand that way because this is my better side. Okay.
Just make sure it's unlocked so Chris can get in with the remote.
I know you're all going to have to go before I get through all these slides, so let me go quickly. When we start out life, we are mostly water. 80% of our body composition is water. And as we get older, one of the things that happens is that we have a decrease in total body water. Why is that? Mostly because one of the things that also happens as we get older is that we lose lean body mass, and wherever there is protein, there is water, and regardless of whether it's muscle tissue or organ tissue or any kind of protein, the total amount of water that we have that's associated with that is going to decrease in a parallel fashion. And actually tomorrow I have some slides that show changes in body composition comparing a 25-year-old who is the what I refer to as the mythical reference male. And are there any dietitians here? Okay, have you ever heard of the reference male? The reference male is a 25-year-old, 5'10", 150-pound male upon whom all the nutrient requirements from the RDA are based, and I've never seen one. So there's one around someplace, but that's our reference male. Okay, well, why is water so important? Oh, you were ahead of me.
Oh, I just turned it just a second.
Okay, no, that's great. Well, water is needed to perform a whole bunch of things, and let me sort of get out of the way. Water is necessary to maintain the homeostasis of the internal environment of the body. It is obviously crucial to regulate cell volume. It serves as an extremely important carrier of nutrients throughout the body, and if you think about the fact that one of the ways that nutrients get distributed, and drugs, I might add, get distributed throughout the body, it's as an aqueous solution. And when we don't have circulation to an organ, such as the feet, for example, then we don't get nutrients there. Water also serves as a really key carrier to help us remove waste, because we excrete waste in several different ways. One is by producing urine, one is by producing stool, and the other is by expiration. And whatever it is that we breathe out, and it probably never gets cold enough here for you to breathe out and see the cloud that forms if you're in a really cold environment. But I come from New York and I'm very familiar with it. And as a matter of fact, I went to school in upstate New York, where it was really challenging in the middle of the winter when it was 3 degrees and everything in your head would freeze, and then you'd breathe out and it would all melt. It was not pretty. One of the really important things that water does, and according to Dr. Katz, I guess you heard some about heat stroke and just reactions to heat. We have it in Arkansas as well. Interesting anecdote, when I very first moved to Little Rock, which is 23 years ago, every year we would hear about deaths of elderly people in periods of high heat. We've had one of those this summer, because we've had heat indexes that have been well into the hundreds for at least the past 6 weeks. And 20 some odd years ago, every summer we would have people who would die from heat exhaustion, particularly our elderly people, particularly our poor elderly people, because they couldn't afford air conditioning, because they were afraid to go outside, particularly if they lived out in the country. They wouldn't go out at night. They were afraid to do that when the temperature was cooler. And their body temperature would dysregulate, and they would dehydrate, and we had deaths every summer for the first number of years. And we started doing PSAs with the local radio stations in particular, to tell people to check on their elderly neighbors and make sure that they had adequate fluid. And it's been a fairly long time. I think we had 1 death from heat earlier this summer, and we haven't had any in a fair number of years, because of the PSAs and because we've raised the public awareness for people to check on their relatives and check on their neighbors. Next slide. Okay, other reasons. Due to a decrease in sweating, older adults are at risk of losing any kind of thermoregulatory capacity, and they have a lot of difficulty in responding to extreme heat and to extreme cold. And so we see a pattern developing here about what it is that we need to pay attention to relative to fluid and hydration. Next slide. Okay, I mentioned before the need to dilute medications. Water is a primary diluent, and whenever we give anything, whether it be oral, whether it be IM, whether it be IV, water is going to be the carrier, and it is the transport mechanism of how most drugs get to their target end organs. What's interesting with older adults is that the dosages for a lot of medications are calculated based on weight, and there is a basic assumption excuse me, the thing that whatever medications are introduced into the body are going to get an even distribution throughout the body because of where water is and is not. An interesting side effect is the whole issue of thirst, and I'm going to come back and talk a whole bunch more about thirst. But drugs may, in fact, impact on thirst, may have an impact on thirst, and impair what is in older adults an already impaired response. Okay, water is necessary to maintain electrolyte concentrations, and we see that clearly whenever we do lab tests. I read a lot of charts, about medical charts, as an expert observer, if you will. I do a lot of legal expert work, And it's really, really interesting to look at labs and compare that side by side with A, the drugs that people are on, or B, the disease processes that they're dealing with. Because oftentimes you'll see somebody coming into the ER, their labs look normal, and I should parenthetically tell you that I was one of the original nutrition support dietitians and learned a lesson a long time ago about intravenous feeding, because they'd come in and they'd look fine. Why? Mostly because they were dehydrated. We'd start feeding them. We'd start a central line. We'd start TPN. I mean, what happens to somebody when they come into the ER? The very first thing that generally happens is that they start a keep open IV before they know what it is that they have to do to somebody. So what are you doing? You're rehydrating them. Well, we'd start TPN, rehydrate them, and son of a gun if all their labs didn't plummet. Why? Because they weren't normal in the first place. Now we were rehydrating them. They were coming out lower, and we would get hysterical. Oh my God, we've got to give more protein. We've got to give salt core serum albumin at $125 an ounce. And try to compensate for something that in fact we didn't need to compensate for. We just needed to understand what it was that was going on. And once we understood what it was that was happening, it didn't worry us that much when their labs plummeted on day 2 and day 3, because we knew that by day 7 or 8 they'd start coming back up again, and what we were doing was not overloading them with things, with nutrients and medications and things that they really didn't need. Okay, so we know that one of the things that we need to do in fluid balance and blood osmolality is to give people fluid and to try to manage their renal excretion of solute-free water, and not have them diurese out, but have them make real appropriately concentrated urine. Next slide. I sort of told you this before, that wherever there is protein, as in total body mass, talking about the protein compartment of the human body, there is going to be water. And one of the things that we hear a lot, because this is also a protein issue, so let me just throw it in here. I'll tell you a story. I got a call one day from a dietitian at a VA hospital in a different part of the country from where we are. And the reason that she was calling me was she wanted to know what we were using for a low protein diet for our elderly inpatients. Going, well, there's one in the VA handbook. There's a low protein diet in there. You know, so all you have to do is look it up. That's what we were doing. She said, no. She said, we have somebody here who won't let us give any of our patients over 55 too much protein because he's afraid that we're going to ruin their kidneys. And I really was speechless, which doesn't happen all that often. I was seriously speechless because, first of all, they were hospitalized patients. So they either had an infection, they were in for some kind of surgery, they had a broken bone. There was something that they were in the hospital for that 90% of the time is going to require protein in order to heal. And he was afraid that they were going to challenge these people's kidneys. And there was at that time a whole slew of literature that indicated that dietary protein has absolutely no effect on an otherwise healthy kidney. And I sent her off all these articles and have been telling the story for almost 20 years because I think it's a real serious mistake to be afraid to give older people the protein that they need. And what we really want to do is to maintain as much, whether it's renal mass or protein mass or liver or kidney or whatever, and it's not going to cause things to sort of decompensate. We do know, however, and a lot of this is from the Baltimore Longitudinal Study on Aging. How many of you are familiar with the Baltimore study? 3, 4, 5. Okay. For those of you who are not familiar with it, 25 words or less, the Baltimore Longitudinal Study on Aging was started in the late 1950s by a group of investigators at, I guess they were at Hopkins. They were in Baltimore, and what they started to do was they started to study a group of subjects, male. I think they entered them at age 30, and they followed them. And as a matter of fact, I think they're still following them. And there is more data on aging, and because they followed them longitudinally, they can link changes in their health status and changes in their physiologic status as it occurs, because these people go back every 2 years and they're weighed and they're measured and they're tested beyond belief. And there are some stunning tables and data of what happens to us in the absence of any kind of disease process, and then the impact of disease on human physiology and human functioning. It's really interesting. From my point of view, this is really interesting because it took them 12 years to figure out that they should include women in this study. And women live longer, so it would be interesting to compare females and males, and it turns out that guys, you wear out faster than we do. Sorry, but okay. Look at that. Baltimore Longitudinal Study dating on age, data indicate a decline in glomerular filtration rates. So we do know that there is a decline in renal function, but that doesn't mean that people have renal disease. Okay, so what do we worry about? We worry particularly about dehydration. I sort of alluded earlier to, I do a lot of legal expert work and review charts for nutritional factors, and a huge majority of them have to do with pressure ulcers. But it's really interesting because they're sort of like this cookie cutter complaint that patients come in dehydrated. Well, some of them do, but many of them don't, and they're making judgments based on no data. I mean, if you're coming in from a nursing home or you're coming in from home into an emergency room, you have to be dehydrated by definition, because that's the way all of these charts read. It's really sort of interesting because there's really no data there that supports the fact that they're dehydrated. Actually, it's really interesting when you read some of this. Sometimes you find out more about people than you really wanted to know. Why is it that a lot of, and talk about free living elderly, are prone to dehydrate? Well, one of the primary reasons is laxative and diuretic use, and laxatives in particular. One of the things that we try and teach our students is to make sure that they ask questions about over-the-counter medications, because if you ask somebody who's coming in to be admitted to bring all their medications, or they're coming into clinic to bring all their medications, they'll bring all their prescription drugs. They won't bring the things that they're buying and using over the counter, or grandma's remedy, or anything else that may they don't consider to be a medication. And you really have to ask about that. And just as a sidebar, you really have to ask about that now more than ever, because people are using all kinds of herbal remedies. And a lot of those herbal remedies, in fact, interfere with prescription drugs and the action of prescription drugs. So you need to make sure that you include that in what it is that you're asking them. But laxative, mostly laxative abuse. It has been my experience, and it may just be within the realm of what I've seen, I don't see that many older adults really abusing diuretics. As a matter of fact, I see exactly the opposite, because there is sort of a low level of urinary incontinence that people, you know, it's not bad enough to go see a doctor about, but they're having stress incontinence, or you know, I don't know what it's called, but when you're urge incontinence, I guess. And so if people are living independently or trying to live independently, they really want to make sure that they can go out, go to the grocery store, or go to the drugstore, or go to have lunch with a friend, and not have an accident. And so what they'll do is they'll self-dehydrate. And I see exactly the opposite. They really don't, at least in my experience, they really don't abuse diuretics. But they do abuse laxatives. And it's something that you really need to ask them about. We see people who are depressed. People who are depressed don't do a lot of things that we wish that they would. We see patients who are tube or parenteral feeding dependent, and you may be sitting there and going, well, but yeah, but they're getting fluids. Well, over the many years of my experience, particularly tube-fed patients, if you look at a tube feeding and you're giving somebody, let's say just arbitrarily, you're giving somebody a liter a day of a tube feeding, you're not giving them a liter of fluid. Okay, what tube feedings generally are is an aqueous solution. It's water with a lot of solids that have been dispersed in it. And when you put solids in water, what you get is a displacement. And so you may have a full liter, but it's not all free fluid. A lot of it is water. A lot of it is this solids. And for the most part, there's a displacement factor of about 25%. And if you pick up one of the canned over the, one of the, like Ensure or Osmolite or Sustacal or, whatever the multitude of products that are out there now, we're getting ready to do a study with Juven, and you read the label, it will say in teeny tiny microscopic print, 740 ml of water, or 750 ml of water. The rest of the liter is actually just displacement. So what you need to do to really give them a liter of fluid is to give them the extra water. So we use a rule of thumb. If you're going to give a liter of fluid, give another for every liter that you give them another 250 cc's of free water. And you can do it if they're taking oral meds. You can do it as a flush. You can do it in between feedings. You can add it to their feedings, but make sure that they get that water. The other issue with TPN, and this is just sort of an old issue, is that we don't give them adequate volume. And we just don't give them adequate volume. And once again, there's also a lot of displacement. I don't know what they're doing these days, but we used to make it with 50% glucose, and there's an awful lot of solute load when you're using 50% glucose, and you're using amino acids, and you're using electrolytes, and you're using vitamins and minerals and trace elements, and you have to compensate for that as well. Polypharmacy is another issue. There are a lot of drugs, and I think I said this before, there are a lot of drugs that will interfere with thirst mechanisms, or will cause water retention, or will cause diuresis. So you need to really pay a lot of attention to that. Another issue is chronic infection, and people run low-grade fevers and may be not getting adequate water to compensate for their losses. Okay, so if we're going to rehydrate people, we want to start with the basic insensible losses. You all know what insensible losses are, particularly at this time of the year, is sweating and that which you breathe out. And generally, we start at about 600 ml as the base. So if you're going to rehydrate them, you're going to start at 600, and then usually what we do is add on to what it is that add on to whatever it is that they're putting out. Sometimes is. If you have acute dehydration, which is going on actively, people who have fistulous losses, people who are vomiting, people who have diarrhea, they may need as much as 2.5 to 4 liters of fluid just to replace that which they are losing. And I think we all know that the challenge is getting this amount of fluid into an elderly patient. So I said I was going to talk about thirst, because thirst, I think, is a significant issue among elderly people. A couple of years ago, I was asked, actually, I don't know if any of you know Ken Meinecker. Ken Meinecker, you do, I know. The Institute of Medicine Food and Nutrition Board was working on fluid and electrolyte guidelines. Those are the folks who give us the RDAs or the DRIs or basic nutrient requirement levels. The RDAs were set on what would keep, and a normal bell curve would keep 97.5% of the population well nourished. Now, there are going to be outliers who need more and outliers who need less. And now we've switched over to the DRIs, and I'm not quite sure that I like the methodology that they're using, but that's a whole nother issue. They were trying to come up with some kind of recommendations for electrolytes. And I was invited to speak to the panel on fluid requirements in older adults. Well, it's sort of interesting because if you go into the literature, there's almost nothing in the literature on fluid requirements. This was about maybe 5 or 6 years ago. Everything in the literature and all the studies that have been done have been measuring thirst. Okay? Nobody has looked at what real fluid requirements are. Now, you may say, what about the 8 glasses of water, 8-ounce glasses of water a day that are recommended? Most of the older people I know would absolutely float away if they took that much water. Most of us, I mean, how many of you think that you drink 64 ounces of water in a day? You do. You must walk around with it. Yeah. But you're young. You're young.
I like you.
And trying, you know how difficult it is to get older people to consume adequate amounts of fluid. Doesn't matter what it is, whether it's water. The only way that I've found to really successfully get fluid into people is to give them something frozen and sweet. You know, like frozen juice or a popsicle or something along that line. And even then, I mean, think about it. You'd have to eat like 10 of them. It gets old real fast. And it's really sort of interesting. Now, in recent years, there have been some attempts at defining real water requirements, real fluid requirements in older adults, but the studies leave a lot to be desired. Let me just say that. Mostly they're anecdotal. Okay. So thirst is a much, much bigger issue in older adults. And the reasons for it have to do with a decrease in aortic baroreceptors. They're sensitive to changes in blood pH. A decrease in osmoreceptors, particularly in the kidney. A decrease in renal function. We just saw that glomerular filtration rate drops as we get older. They voluntarily limit their intake, and I sort of told you about that a couple of minutes ago, because if you are afraid that you're going to have an accident, you're going to self-dehydrate before you go out shopping. I mean, and people do that purposefully. There was, I used to get tickled by the fact that I would give a lecture and say, well, the only people I know who were talking about incontinence in public were me and June Allison, and she was selling Depends and making a whole lot more money than I was. You know, everything in life is timing. But people don't talk about it. We really don't talk about it, except for the urologists, and they talk about it in terms that we sometimes have to sort of really get into to know what is it that we should be doing for people. And brain injuries, and mostly that's when you don't wear a helmet when you're on a motorcycle. That's true. Okay, so voluntary intake tends to decrease because of a mild incontinence, because of what it is that I've been talking about, of people having a stress incontinence or an urge incontinence, or an incontinence that if they don't drink, they think they can manage by themselves. And once again, you know, why go to see somebody about it if, you know, if it only happens when you've been out shopping You know, there's a term for this, and I don't know what it is, but have you ever, I'm sure you've all experienced it, where you've been out, you're driving home, you get home, and the first thing that you have to do is go to the bathroom. There's actually a name for that. Does anybody know what that is? There's actually, I'm sorry, I don't remember, I tell you, but I mean, that's a serious question. I don't know what, there's a name for it. But it's sort of like situational incontinence. You know, you're out and you know that you're going to be home in 5 minutes, and oh my God, you have to go to the bathroom really, really bad. And you know, you'd probably go another hour if you were out and being busy and stuff without feeling like you had to go to the bathroom. But boy, you know, you're 15 or 20 feet away from the bathroom, and you have to deal with that. Inconvenience if you just don't have it readily available. You know, I wonder now about, I don't know if any of you, have any of you been on an airplane lately? You cannot bring anything liquid onto the plane with you. This is my second trip in less than a week, and it's amazing. They have these great big bins where people are taking bottles of water out of their purses and out of their carry-ons and out of their briefcases because you can't take it on the plane. And if you go through and buy one, you know, if you get through security and you buy one, you've got to finish the whole thing before you get on the plane because they will not let you take it on the plane. And I sit there and I look at some of these old people who are sitting in wheelchairs because they can't walk, and I thought, and you know, I wonder how this is affecting them. I mean, really and truly, because I don't know where she went, but she'd be very unhappy because she'd have to give up her water bottle to get on an airplane. At the moment, anyway. They're now letting you take, if this matters to anybody, they're now letting you take solid lipstick. You can't take lip gloss because it's a gel. You can't take mascara because it's a gel, but you can take a solid lipstick. I don't know who makes up the rules. Okay, we know that older adults have a decreased thirst sensitivity, and if you, I'll just tell you one really quick story. A number of years ago, I had rented a house in St. John, and my mom had come with me down there, and there were a group of us, and my friends, and everybody loves my mother, so we took my mother. And it was June, and it was really hot, and we were in St. John's, you know, in the Caribbean, and every hour and a half, somebody would get up to go into the house to get Diet Coke, to get a bottle of water, to get some juice, to get something fluid. And every single person who went into the house would ask my mother, would you like me to bring you something? No, I'm not thirsty, she said. In the meantime, she's sitting out there in this 90-degree heat and she's baking. So we just decided that we would just bring her stuff. And we would bring her a nice tall glass of iced tea and put it right next to her. And because it was there and it was right next to her, she would at least sip at it. But if you asked her if she was thirsty, she would deny the fact that she was thirsty. And it was sort of an interesting kind of an observation because, you know, I talk about this a lot, and when you see it really happening, and it's happening to your parent, that's sort of, you know, like external confirmation. Demented patients will often not drink. They just forget. I mean, is basically the bottom line. I once had a patient who had psychogenic water drinking. Have any of you ever taken care of this? Have you? This woman, this was a long time ago, she would sit in bed and have the tray table in front of her. She was probably 40, with a glass of water and her cigarettes and her lighter and an ashtray, and she had them all lined up on her bedside table, and nobody would believe it. I mean, I could see her room from my office, and so I knew that she was really drinking this stuff. This woman was taking 10 liters of fluid a day. 10 liters of fluid, because every time that pitcher was empty, we would take it back into the kitchen, measure out another 1,200 cc's, dump some ice in it, and give it to her. And I promise you that she was drinking 10 liters of water a day, and we just all just sat there, you know, with our mouths hanging open. Where was she putting it? Because she didn't go to the bathroom as much as we thought that she ought to have for that amount of fluid intake. So sometimes voluntary intake is inadequate, and in most people this is in fact the case. They're just not taking in enough. But the question is, do we need to go to 8-ounce glasses a day? Probably not. Let me just tell you one thing before we go on. In this conversation that we had with the Institute of Medicine Food and Nutrition Board, we were speculating about where it is that that came from. And I just want to share with you what it is that we came up with. Now, whether it's legitimate or not, I don't know, but it made sense to us. Nobody knows where it came from. It's sort of like the turning patients every 2 hours to prevent pressure ulcers kind of a thing, which came out of a paper out of England that were recommendations. No data, but recommendations, okay? Well, in the 1930s, there was a move in this country, before any of our time, there was a move in this country, a health thing. And people used to go to camps to get healthy, and one of the big ones was in Michigan, in Battle Creek. Does this start to sound like maybe you know where I'm going with this? Okay, Battle Creek, Michigan. And it was run by Kellogg's cereal company. And they were feeding everybody several bowls of bran cereal a day. And so they were making them drink 8-ounce glasses of fluid a day. Okay, because they were taking all the bran, and if you didn't give them adequate fluid, then they would get obstructed. So we think that maybe that's where it came from, because as far as you go back in the literature, if anybody finds an article that says that we need 8-ounce glasses of fluid a day for people who are not elite athletes, please let me know. Just email me. Okay. Actually, we think that probably if you can get 6 8-ounce glasses of fluid a day, you're doing well. Michelle was so mesmerized by my story. This is a common misconception that dehydration, the difference between dehydration and volume depletion. Dehydration actually refers to intracellular water. And it has to do with hypertonicity, where we're actually concentrating electrolytes. And we may have some kind of disturbance of water metabolism. It doesn't really happen as frequently as I think that it's reported, because I have read my fair share, like I said, of charts. I had one case that the non-facility records were 11,000 pages. I've been shredding for a year to try and get rid of it. But every diagnosis is dehydration, and then there's nothing to support it. It's just a clinical judgment and not a real diagnosis. Okay, dehydration does require some lab analysis. And the two things that tend to at least support it are sodium levels that are concentrated, or serum tonicity, or urine-specific gravity. I don't remember the last time I saw urine-specific gravity done in a nursing home patient. On the other hand, volume depletion is a decrease in the extracellular fluid, and it's more related to a loss of total body sodium. Okay, so when do we look for dehydration? Dehydration may be associated with hypotension, with an elevated body temperature, and that's part of what happens with heat-related deaths, is that body temperature goes up, or the ability to maintain homeostasis is lost. We see constipation, which is sort of hard in older adults because so many of them are constipated for other reasons anyway. We see people who have nausea and vomiting. particularly oral mucosal dryness, decreased urine output. My personal favorite is mental confusion, because it's amazing to me how many patients come into the hospital who are really confused and probably a little bit delirious, and you start an IV and you rehydrate them in a couple of hours. They are like they don't know how they got to the hospital. It's really sort of interesting. And I'll tell you, it happened to my father once. And he had no idea how he got to the hospital, but he had totally decompensated. And mother called 911, and they took him to the hospital and started that IV, and he was really out of it for about 12 hours. Got up at 1 o'clock in the morning and went to look for my mother. Didn't know where he was hooked up to an IV, so he was dragging the IV behind him, and I thought the nurses were totally brilliant. They just picked up the phone and called my mother. He's looking for you. This is one of these, I don't know if any of you have had this experience. So my mother calls me at 10 o'clock at night and says, well, I just wanted to let you know where I am. And I'm going, it's 11 o'clock at night your time. Where are you? You know, I hope you're at home. Well, I'm at home, but let me tell you where I've been. She calls me at 10 o'clock the next morning. Well, I just wanted to let you know where I am. I said, Mother, where'd you go since I last talked to you? Well, and she told me this whole story, that they called her from the hospital at 1 o'clock in the morning, and she went over to keep my dad company in the middle of the night because he was looking for her. And it's, you know, it was when they were doing those the commercials, it's 11 o'clock at night, do you know where your kids are? Well, you reach a certain point in life where it's 11 o'clock at night and you know where your parents are. Elderly people in long-term care tend to have high plasma osmolality, and whether there's a cause and effect relationship, I wouldn't venture there, but you just never know. And I will tell you that they all come into the hospital with a diagnosis of dehydration. I mean, virtually all of them. At least of the ones that I get to review. Maybe the ones who don't end up in lawsuits don't have the problem. Okay, we want to move on. I don't want y'all to feel like you have to stay. Dehydration is usually treated with just D5W, and if you're going to, okay, extracellular, so volume depletion is treated with just normal saline, and that's a cheap, easy way of restoring fluid balance. Some people use this. It is not terribly practical. If you are going to be doing a research study and you want to do it and you happen to have the equipment, go for it. But it's really not used clinically. It's really no reason to use it clinically. It's not terribly sensitive. The equipment is expensive. It takes a while to do. And there are probably other things that we can do that are a lot more reliable estimates. As I mentioned before, clinical evaluation of hydration status is really quite difficult, and everybody has a different approach to it. We can do skin tenting over an area where there's little subcutaneous fat, back of the hand, supraclavicularly, someplace where there's not a lot of fat, and you can do skin tenting. It's purely observational. It's, I don't think, terribly scientific. You can look in somebody's mouth and look at a dry oral mucosa, people who have orthostatic hypotension. The one that I really want to just address for a second is rapid weight loss, because I have read more than my fair share of legal complaints, and actually I've read more than my fair share of depositions too. It's really amazing that people say, oh my God, this woman went into a nursing home and she lost 30 pounds in the first 10 days that she was there. Well, it's physiologically impossible to do. And the only explanation for rapid shifts, you can't gain, despite our own personal experiences with chocolate and other such foods, you cannot gain that much weight in that little a period of time. Nor, unfortunately, can you lose that much weight in that period of time. And basically what you're seeing are shifts in fluid. And it's really interesting. I had one of the dietitians at our VA came running down the hall, dragging one of the dietetic interns behind her. This woman is taking so much fluid, and we don't know where it's going because she's just not putting it out. And I said to her, what is she doing? Well, she's in bed. She's lying in bed. And she said, and we looked at her feet, and she doesn't have any pedal edema, and she doesn't have, you know, we looked all the way up her leg, and she doesn't have any edema. I said, did you roll her over? And they looked at each other, and they went charging back. I mean, it was like a herd of elephants. They went charging back down the hall, and they were gone for about 10 minutes and came charging back. Guess what? This woman had 4+ pitting edema sacrally, because that's where she was lying. And you know, we all know that water seeks the lowest point, and because she was lying in bed, it ended up in her back. I figured somebody learned something that day. But these fluid shifts are rapid, and they're not uncommon, and you cannot lose 30 pounds in a week without having the limb amputated. And actually, sort of a sidebar comment, I have seen people with above-the-knee knee amputations, and their weight is reported exactly the same after the amputation as it was before. And I can't quite figure out how to get my brain around that one. Okay. Next slide. Okay, laboratory measures, and once again, you have to be really aware of what it is that you're paying attention to. I think that the best measure is to look at serum osmolality or urine-specific gravity. All right, that's just, you all know that. Okay, so how do we estimate fluid requirements? There are several different ways. One way is to calculate 30 ml per kilogram of body weight. The problem with this, I mean, I think that this is a good rule of thumb to start with, but the problem with it is that we have a lot of very small, older women who will not really get adequate amounts of fluid if they only take 30 ml per kilogram of body weight. One suggestion is to calculate 1 ml per kilogram per kilocalorie consumed. Well, that's even worse because some of our small, frail ladies who are non-active are only consuming 800 calories a day. That means you'd only be giving them 800 ml of fluid, which is not adequate. That will barely cover their insensible losses. This one, I say anybody who wants to do this, more power to them. Okay? 100 ml for the first 10 kilos, 50 ml for the next 10 kilos, and 15 ml per kilo above that. It's in the textbooks, what can I tell you? Not mine. Okay. My way of doing this is to start with the base of 30 ml per kilogram of body weight and shoot for a minimum of 1.5 liters a day. And if you can do more, that's great. But a lot of people don't take 2 liters a day, except you. Okay? And we really need to pay attention to it. And the very first time I got to talk about this, I was talking, it was actually a cancer meeting, I was talking about chemotherapy in older adults and the need to keep people well hydrated so you flushed all the chemotherapeutic agents through your kidneys. And I looked down to see what slide was next on my list, and I looked up, there were 200 people in the room, everybody was pouring water. It sort of reminded me of halftime during the Super Bowl, you know, where every toilet in America is flushed at the same time. 1,500 ml a day is a reasonable amount to attempt to get into people. And I would challenge you to pay attention to how much fluid that you actually consume in a day. Because even if you're walking around with a big bottle of water, you may not be drinking the whole thing. You are, but nobody else may. Okay. The number and frequency of medications and getting people to swallow pills and try and get them to drink more than the you know, the little medicine cup full of water that we often give them just to take their meds with. It's really, really, really important to keep fluid accessible, which means on the bedside table where they can reach it, or wherever it is that they spend most of their time. It is a classic story of an older woman in a jerry chair. Actually, this, I've still not quite gotten it, wrapped in one of those white, you know, those ubiquitous white thermal blankets. And she's sitting in the jerry chair. The nurse or diet aide, I don't even remember anymore, brings her dinner in, puts it on the bedside table, puts it in front of her, lowers it, and walks out. Now this woman is wrapped in a blanket. There was no way that she could lift the lid. And I happened to be there at the time because I was running 104 temperature, and on the and her pitcher of water was on her nightstand, which was about 5 or 6 feet behind her. And I knew I was dehydrated. I mean, I was really sick, and oh, I wanted that water, you know. So my eye just sort of went right to the water, and then it occurred to me, you know, how on earth could she get it? She couldn't even, I mean, she was all wrapped up. It was sort of like, you know, she was like bundled. And it really made, it actually made a very, very strong impression on me. And one of my friends at the time was the associate chief nurse for a long-term care facility in North Little Rock. And she came to visit me when I was in the hospital, and I told her this story. And she went back to the VA, and she started to look at where it was that they put all the water pitchers, first of all, and second of all, where all the call buttons were. You know, and we have a tendency, at least at that time, to pin them to the bed sheet. Well, she wasn't in bed, so if she needed something, there was no way that she could have reached it. Now what they do in Little Rock is they pin them to the pajamas, so that it's right there. It goes with them wherever they are in their room. But it's just, it has to be accessible, and it has to be manageable, which means that you can't put a great big pitcher full of ice there and expect anybody to lift it, and much less pour it. And we need to pay attention to those kinds of things, and particularly at this time of the year when it's so hot and people really do need adequate hydration. How many more are there? Because
I don't know.
Huh?
I don't know.
No, you don't. I think this is the place to stop. Okay, and you have the rest of the slides, but I know that I started late, and I know y'all got places to go, and I'll take any questions, see if I can answer them. Or thank you very much for staying.
Anybody have any questions?
Using lab values, like urine-specific gravity, I mean, we still get that on our routine urinalysis.
I'm sorry,
We still get that lab value on our urinalysis, and when you said that older dogs can't concentrate as well, what would you have as your parameters for being concerned?
well, I would look at two things. I wouldn't just rely on one lab. I would look at two things. We see the same thing with serum albumins. They'll draw a serum they'll draw a lab and look at the serum albumin and get hysterical. Oh my God, this patient's serum albumin is 2.8. They're malnourished. Well, generally that's not the case at all. It has to do with something else. And certainly with that, I've always taught people to look at the calcium and to see whether or not there's any kind of an inflammatory process going on. But I would look at the BUN and try and put as much together as possible. I don't think that specific gravity changes that much with age. I just think that the kidney has to work harder. You had a question?
Oh, I was thank you for the 8 glasses of 8 ounces. Well, that never made sense, and I say it's so nice to hear kind of where it might
Oh, you're welcome. Yeah. My other thing is the turning patients every 2 hours, because I know that they've been turned every 2 hours when they've got pressure ulcers on both hips. You know, then they're
even.
Yeah, then they're even.
Any reference? I mean, if someone were going to want just a nice sort of brief nutrition in the elderly, up-to-date reference, what you would recommend?
Well, she asked me.
She has a book out.
There's a book. terrific book. It's called Geriatric Nutrition, the Health Professional's Handbook, and the 3rd edition came out in February.
But if they were to look for an article that gave them a good general overview, what would that be?
I'd have to think about that, but I'd be happy to think about it and send Michelle a reference.
Okay, and I'll pass it on.
Okay, thank you.
I mean, I've just spent this weekend deep in textbooks because for the dietitian, there will be in January a credentialing exam in geriatric nutrition, and we're writing the items right now. So, if any of the dietitians are interested in taking it, it's going to be given in January for the first time. And I'll just give you a hint that there will be questions about dehydration and fluid health.
I have a question because I'm staring at this Diet Pepsi over here.
Uh-huh.
Now, somewhere I heard that for every soda you drink, because of the sodium in the soda, you have to drink that much more water. Is that true for those people who don't know that?
No, but it's a good idea to drink free water that's solute free, because it'll compensate for the stuff that you're drinking that's not. You know, people used to get all hysterical about the hypertonicity of tube feeding formulas. Well, if you pull out Merck's and look at there's a table of the tonicity of a lot of different fluids. You know what the one that's the highest listed there is orange juice. So I'm not saying don't drink water. I'm just saying that I don't think that we need 8-ounce glasses a day. And I think that drinking free water is, a lot of these diet sodas in particular tend to act as mild diuretics. So you probably want to drink more water to compensate for putting out more urine. But, you know, but almost anything has solute load in it, with the exception of just water, and even some, you know, water does too, unless it's, okay, I'm blanking. Thank you, distilled water, which is awful. If any of you have ever had the opportunity to taste distilled water, it has absolutely no taste, and it's flat. It's. My first job was in a metabolic research unit, and we had a still. And so when
Was this in Arkansas?
No, in the mountains, New York. This was in New York.
Okay, just
Catskills.
Yeah.
No, but you know, why didn't we ever think of that?
Well, yeah.
Yeah. No, we had to climb up there and change the filter every 6 weeks or so. But in a pinch, we drink the water, and it was terrible. It's just terrible.
I had a question. As a purist, when you mention body weight, we always like ideal body weight versus actual because of the distributions and the different body systems, because, you know, it depends what that weight is. You're assuming.
Well, I'm not quite sure that I have ever understood what ideal body weight is.
See, that's me. And I'm like, you know, because you talk to nephrology type people, and they're always doing this ideal body weight. And I'm like, well, show me an ideal person.
Yeah, exactly. Well, my mythical reference
yeah.
male.
So you're purist or not?
Yeah, ideal. Let me tell you where ideal body weights came from. Okay,
Yeah, back when
1958. Yeah, the Metropolitan Height and Weight Tables were published, and I have a problem with anything that doesn't include a woman who's my height. If I were 5'8" and wearing 2-inch heels, then I'd be 5'10". I'm 5'10" with, you know, flat, and I'm never on any of the tables. What they looked at was you know, actuarial tables, that if you are X number of inches and weigh X much, they project out at what weight for height you would live the longest. The problem is, was A, it was done 50 years ago, B, there were no minorities included, C, it was a population of like 300 people, and we sort of got hung up on this ideal body weight thing that has never made any sense to me. And I would rather look at actual weight and then say, but this person is clearly, you know, overweight, needs to reduce, or this person is clearly underweight and needs to put weight on. You know, there's getting to be more and more controversy about even using body mass index.
Yeah, I know.
I always thought that it was artificially low, and that there's some interesting data that I have got to find this article because I have slides with data from this article that was published in the Journals of Gerontology, and I'm thinking sometime in the late 80s. And what they did was they looked at predicted mortality and charted it against diagnosed disease and weight. So those were the three factors, or the weight and the disease at the time that the study was done anyway. Sort of looked at who lived longer, who had the lowest predicted mortality, and it's actually a J-shaped curve. Okay, and the bottom of the curve is someplace between a body mass index of 31 and 32.